So I would like to also introduce Isabel Scarinci, who's from the University of Alabama at Birmingham, who does work on the application of behavioral science to public health by promoting behavior change at the population level. Her work focuses on cervical cancer and tobacco prevention and control. She's going to be speaking more about her work around non-tobacco stuff tomorrow at the sessions, but we thought she could join us a little bit and talk about her work on tobacco control during the panel. So if we could just start with a brief introduction from you and anything that you'd like to tell us about your work.
Everybody prepared our slides, and I don't have any. So I just, the speakers did such an outstanding job, and I just want to say 2 words thinking there on my work. I work in Alabama, where prevalence of tobacco use among African American men in rural Alabama between the ages of 19 and 30 are 40%. So if you look at the behavioral risk surveillance system for Alabama, for African American men in that same age group is 15%. So I think it shows the needs for us to focus in specific populations. In contrast, my other work is in Brazil, where Brazil has been a model for the world in tobacco control. So I think that for us, and my work is funded by NCI and Fogarty in Brazil, and sometimes it's embarrassing because we are much worse off than Brazil. Brazil now has excellent regulatory agency that we don't have. Prevalence has gone down. Today, prevalence of smoking among women in Brazil is 11%. Brazil didn't even let the e-cigarette in. So it's a lot of regulatory changes that are making a huge difference. And so walking in these 2 settings has been an interesting experience, and I think it reflects what the panel has talked about.
We'll start a question from Kathleen.
Hi, Kathleen Schmaler from MD Anderson. So at MD Anderson last January, our institution put a policy in place where for all new employees, so all new employees get drug tested, but now they also get tested for cotinine, and anyone who's a smoker can't get a job there. So it's a very bold statement by MD Anderson, and obviously there's a lot of controversy both within the institution and in the Houston community, especially since now you can have a gun on the UT campus and we're part of the UT system. But everything, right, exactly. So the controversy has definitely died down, and I just wondered if that was common other places and if there's any evidence that these types of things make a difference.
So regarding the issue of not hiring smokers, I've always been opposed to that. And the reason I've been opposed is that people who are smokers, they did not choose to be smokers consciously as adults. Most people are addicted to smoking before they graduate from high school. We allowed them to be marketed and solicited and addicted, and now 70% would like to quit. And to then further discriminate against them because they have an addiction and not have employment, I think is a wrong policy. I think I'm in a minority on that, but I do have strong feelings about that.
Yeah, it's certainly a controversial policy. There are people that think you should make sure you offer cessation support for your employees that want to quit. Or who use tobacco, and also, create smoke-free environments or tobacco-free environments and things like that. The WHO a few years ago actually passed a policy of not hiring smokers and providing cessation support for those. And it does seem, though, that it creates a big brouhaha and dies down. So I don't know if anybody has looked at any long-term impact of these policies other than what we see in the media. It is interesting, though, because apparently the late Ron Davis, at that time of the WHO policy, was outspoken, and there are apparently several other professions that do not hire smokers. And so it's unique in terms of healthcare facilities maybe, but it's not unique in terms of a policy more generally speaking, and that's what I learned. So as you said, it seems that it goes away, and it would be interesting to look at any long-term consequences in terms of recruiting and retention.
So my own institution, University of Alabama, Birmingham, we did that, and it was the same thing. But we made sure that we offer assistance for, because you cannot do that without offering. Now, this just happened. I'm looking at my colleagues here at UAB. Now, they're going one step further that we'll see how it goes. Everyone who is a tobacco user is going to pay $50 extra on their health insurance. So that one is brand new, and of course there is a transition period that if they go through cessation and offer all that, and so that just happened like last week, and we'll see how that goes.
In the Philippines, there are initiatives among some of the local governments to also not hire smokers. Those that are going for completely smoke-free, tobacco-free cities, where you can't, where almost all of the FCTC measures are truly being implemented and enforced. There is the issue of discrimination, but those who are already hired but are smoking are offered cessation services, and it really is to encourage them to walk the talk and give the public a really good example of what a government official should be doing, rather than promoting tobacco with his actions. Even in our police force, there is a directive for smokers among the police not to be seen smoking in public when they're in uniform. So there is a move to denormalize the smoking, but also at the same time not to criminalize the smokers, because they are, as Mike said, the victims of the tobacco industry.
Just a couple of follow-up. In China, there was a similar directive that Communist Party officials should not be seen smoking in public. They don't comment on their own smoking behavior, but the representation of them smoking has been prohibited by the party. The other thing, in terms of the incentive or the penalty for being a smoker for health insurance, we did that about 2 years ago in Georgia, and it was $50 a month surcharge if you are a self-proclaimed smoker. And we found out that I asked what percent of the employees so indicate, and I think it was 4 or 5%. So, this is primarily, blue-collar staff, and so, national smoking rates are 16%, probably blue-collar staff is probably around twice that. So there's a fairly high level of underreporting that goes on with those types of policies.
Julia Rowland, National Cancer Institute. So you can carry a gun, just not a smoking gun in Texas. But you know how hard this is to do. So now I would say, I'm trying to think how long ago it was. Memorial Sloan Kettering pushed smoking outside, and I can remember very vividly people coming in. You had to come through a haze of smoke because all the staff were outside and patients with their oxygen tanks parked outside this wonderful institution. But I would also remind you, Surgeon General's report, thank you for reminding us about that, came out in 1964. The NIH campus did not go smoke-free until when? 2008. So the National Institutes of Health campus did not go smoke-free until 2008, with great kicking and screaming. Reluctantly did that go through. My question to this smart, dedicated group is, so how do we get the framework adopted by the U.S. government? What's it going to take?
I'm going to avoid answering your question, but I am going to say anecdotally, and Bernard will remember this, I was at MD Anderson when I was responsible for MD Anderson going smoke-free in 1988. And Mickey LeMaitre was president at that time, and those of you who know him, I just heard he's 92 and writing a book. God bless him. But he was on the first Surgeon General's report in 1964. So there's some history and continuity here. And we had the same pushback about how could you be so cruel to cancer patients to make them go outside with their IV poles to smoke. And when I first went to MD Anderson, you could literally not see across the cafeteria inside because it was so smoke-filled. And that was in the early 80s. So progress has been made. I will pass on the FCTC or think of, try to think of a.
From the non-U.S. perspective, there is a group of us who feel that it may not be beneficial for the rest of the world if the FCTC is ratified by the U.S. One of the reasons for that is during the negotiations for the treaty itself, the U.S. many times was a stumbling block towards effective provisions going into the treaty, together with countries like Germany and Japan and China. So while it may be beneficial within the U.S. to ratify, outside of the U.S. there is that problem. For example, just the TPP, for example, Trans-Pacific Partnership being negotiated, the U.S. Trade Representative many times would speak on behalf of the U.S. industry. So that would be Philip Morris primarily. And getting the carve-out for tobacco, I think, was a big success, in terms of tobacco control. But how that resounds throughout the rest of the health sector is a different story. So just keep that in mind. I think it is possible to still implement the treaty provisions even without being a party. So, for example, Indonesia, in our part of the world, is not a party. The U.S. actually has signed the treaty, not ratified, but Indonesia has neither signed nor ratified. But they have graphic warnings, a step in the right direction. They don't have anything else, but they do have graphic warnings. So we're hopeful that even without being a party, you can have effective tobacco control.
Yeah, I was just going to add that my understanding is that the U.S. doesn't have a great tradition of ratifying treaties, period, regardless of the topic. So it might be that it's just not what foreign policy is. But again, it doesn't keep, the evidence base is there, and countries that are not parties are implementing bits and pieces. Another example is Argentina, who is trying to move towards 100% smoke-free nationwide. And doing some other measures, and they are not a party of the treaty. So there are some examples that you could use those evidence-based policies and implement them regardless of your access to the treaty.
Dr. Palafox?
Quick question on cultural influence. For cancer control, what is the evidence around statements like if you're Native Hawaiians is not part of your tradition, so don't smoke, or if you belong to a part of a church, if you belong to a part of a church, I'm just using this as an example, you're a Christian and Christians don't smoke. Is that what is the evidence around that working, not working? Is that a good strategy, not a good strategy?
So you notice that in the Philippines, we call our tobacco tax a sin tax. In other countries, it would be called a health tax. And the reason we do that is because we're primarily a Christian nation, primarily Catholics, and we think of it as a very bad vice. So that actually helps reinforce the idea that people should not be smoking because there is a large religious influence in the country. Similar to Islamic countries, the Organization of Islamic Countries actually has an agreement that they should actually be very strict with tobacco control. How it's implemented at the country level is, of course, different. So Indonesia, for example, is primarily Muslim, but they have very bad tobacco control. So I think it is based on cultural context at the country level where we need to be thinking. When it's feasible, we actually do use that argument, and it has been useful from time to time. But it's not always the case. So we ask the people on the ground, our friends on the ground, depending on which country we're in. It is actually quite helpful when there are large numbers of, so for example, in Thailand or in Cambodia, there is a large Buddhist population, and they've had their chief monk actually say that people shouldn't smoke, and that has helped reduce the number of people smoking. So I think that really is case to case. We haven't done it across the region to say that we should be using religious influence. Culturally, the tobacco industry has also tried to do that. So for example, in Indonesia, just very recently, there has been a bill filed in their parliament to say that the kretek, the clove cigarette, should be a cultural heritage of Indonesia. And if that happens, then it becomes quite taboo to attack. Fortunately, the bill was challenged by many people, many sectors, and that didn't push through.
Yeah, I was just going to say that it depends on the context in which it's used and how it's used, because you don't want it to backfire. So another example I think that we could provide is Native Americans' use of tobacco, and being somehow co-opted in parts by the tobacco industry by saying this is your cultural heritage to use tobacco for your ceremonies and things. But now a movement among Native American community organizations to counter that, and the difference between commercial tobacco versus traditional tobacco use. And I think like Navajo Nation, for example, making great strides to implement smoke-free environments, smoke-free casinos, and things like that. So a lot of the, unfortunately, a lot of some of the cultural more than religious, but a lot of cultural heritages have been hijacked in some ways by marketing strategies from tobacco companies in many places, where you associate something that would be very culturally relevant with tobacco use. Brazil, where we are from, they have had in the past campaigns where you associate going to the beach on a Saturday with cigarettes, where we have special promotions of cigarette packs that will have a special wrap so they wouldn't get wet. So it's the cigarette for the beach type thing, you know. So trying to explore some of the things that are part of your culture and use. So I think it has to be done, like you says, we're very careful. If you want to use some of that heritage for tobacco control or for cancer control, you have to make sure that there is good community-based support to make sure you're going in the right direction and in a way that touch. Just another example on the religion effort, there is a group in the south of Brazil, Catholic diocese, and for 25 years now, they have worked on replacing tobacco crop to the point that this was a major tobacco growing area, and now they don't. And it was because they took a religion, the diocese took a view that that was their job to help those tobacco growers find an alternative livelihood. And it's been incredibly successful, and it was, again, but it was done within that community level context. So I think anything using that has to really take very carefully into account the community context to make sure it doesn't backfire. But it could, there are many examples where it has been for good results, culturally and religiously used for good results. I don't know if you want to.
It's just a lot of it also has been on social norms. So Brazil, actually, we are working on this paper. We are comparing the discourse of women in 2000 and now. Now Brazil has a federal smoke-free policy indoor. So, and the discourse of the women has changed. Before the, in the 2000s, Brazil was a booming, growing, and was about glamour. Women start smoking in the happy hours and all that. And now, 15 years later, the discourse is embarrassing because they have been ostracized. And so it's amazing to see in a country that big how the social norms change, but because of legislation and because of all these other, not specifically efforts in changing the social norms, but the whole legislation and regulation has had a huge impact in changing the behaviors.
think we have a question from Dr. Erickson.
Just wanted to ask a question to the audience, and that Stella talked about the role of health professionals, physicians and nurses in smoking cessation, and then there's been, so my question is the interface between primary prevention and screening. And so, as you all know, there's been recommendations for spiral CT scanning for the early detection of lung cancer, which hasn't been discussed here, but is now being implemented and reimbursed for. And there was an article in JAMA recently that looked at participants who are long-term smokers who were going in to get a spiral CT for early detection of lung cancer, and they concluded that after they came out from their x-ray and got the results and saw there wasn't a tumor, their interest in quitting smoking decreased. And so what do we do in this instance where, I don't know if there's a parallel with the other screening procedures we talked around breast cancer, where your behavior really won't change if you have a negative mammogram, I don't think, or other type of, but in this case, lung cancer screening was being seen as providing reassurance that translated into continuing smoking, which is really not a good outcome from that. So what ideas or suggestions or thoughts do people have about that?
Anyone is welcome to go to the microphones, but I'll start with the panel. Do you have any comments on that, or are there other areas in smoking cessation that have a similar, where we see similar issues with demotivating factors?
So I'll do the Latin way, think out loud. I think that's, your point goes, part of it is where with now the new breast cancer guidelines, the weight, the burden is put on the provider. I think that discussion, because I think to send a patient for a lung eye screening unprepared, it's the whole discussion we have in the screening group about harm. And that, I think that would be my first hunch. I think we need to understand, being a psychologist, how why I'm not familiar with the paper. In cessation, the demotivation is not so much, it's more the self-efficacy and the relapse, and that kind of, no, I can't do it. And then they started kind of going through, well, my lungs are okay, but it has much more to do with self-efficacy, not so much demotivating. That's what we see mostly.
Yeah, we have a comment from the audience.
Hi, Fabio Almeida from Virginia Tech, and just addressing the question around, we've done some of the work that I do is around promoting physical activity, and we've done some work with folks that have been, they're cardiac patients that were referred to do a cardiac treadmill stress test. And basically what we did is, because a lot of times when they would go to those cardiac treadmill stress tests, they would get the negative indicating that everything was clear, and then they would go, hey, so everything's clear, I'm no longer at risk for having a heart event, and they would go home and go about their lives. And then if you're trying to engage them at that point in time, they didn't want to talk to you about whether it was physical activity interventions, weight loss, or any of those types of things. One thing that we know from the literature is that those folks, even though they had a good stress test result, they are at a higher risk for mortality than those other folks. So what we did, we developed a program where we worked directly with the exercise physiologists that were doing the actual stress test, and then right at the end of that stress test, even though, for those folks who had that negative, which was good, their results were good, then they were referred to the program right then and there, and then we worked on self-efficacy and some of those different kind of behavior modification types of things. But the idea was that we engaged those folks right at that point where we're trying to capitalize in the fact that they may have the heightened sense of severity, because if their doctor referred them to a cardiac stress test, so there's a problem there. But then now you have that thing that, well, the test is negative, so now I don't have that problem. So we try to capitalize on kind of trying to do some work with that, and we've shown that there's definitely evidence-based things that we can do with those folks. So I'm assuming that it's something similar with those with cancer screening and those types of things. We're actually in the process of identifying partners to kind of develop similar programs with screening types of things that we can develop with them. I'm new to the cancer side of things, so we'll, anybody who's working on that, just a little plug.
Yes, please, go ahead.
Yeah, so I think that's a very good point, and I think what I have seen more recent is that an increased call to make sure any screening is attached to a cessation intervention, repeated because of relapse. So I think it's a reflection a bit of our high reliance, and I think was discussed a bit this morning, on intervention that includes some sort of machine versus something that is just person to person or advice. So you want to do something. The other issue is, I think, the lack of this more holistic approach. So somebody's so focused on lung cancer that's like, well, you may not, your screen might be negative, but you may have a heart attack tomorrow, and tobacco kills a lot more people from heart disease than they do of lung cancer. So again, it's not seeing the person as a whole. It's like, okay, you may not have lung cancer, but you may have something else, or emphysema. And so I think I have seen a lot of calls for screening to be implemented in conjunction with smoking cessation, otherwise not do it. And I think there has been studies looking at the benefits of cessation with screening. So there are some studies looking at that.
There has. I believe Medicare requires
Yes.
that smoking cessation be provided in order to
For them to pay,
cover
yeah.
the screening as well. I think there's a lot around lung cancer screening interventions implementation that we need to understand better, since it's such a new technology. Since we don't have anybody up at the microphones, I thought I would take the chance to pose a question to the panel around if you could speak a little bit to these, your experiences with tobacco industry interference, and to what extent are there experiences that are unique in low resource settings compared to settings where there are more resources, or do you feel like the strategies employed by the tobacco industry are pretty universal across contexts?
I'll start. I mean, I think that the strategies are universal, but the response differs in that in some low resource settings, they can ride roughshod over governments because there's not a strong governmental response or a regulatory system that could, to the point where Mike Bloomberg and Bill Gates had to provide money to make it available for countries to defend themselves against the tobacco industry. That says it all there. But I think the strategy at a broad level of that was so well described by the Philippines Finance Committee. I mean, what they try to do, the levers they do about how it's going to hurt the poor, like they care about the poor. I mean, in the industry that is, et cetera, are tried and true and get replayed. The issue is how well do they get defended against, and what kind of traction do they get? And it's not just an issue of low resource versus high resource. It's an issue of political will, a willingness to stand up, the regulatory structure that's in place in a country, the advocacy that exists, the lawyers that are available to help defend countries against these assaults, are all go into that mix.
Just to echo a bit of what Mike said, in Laos, when they were trying to pass their tobacco control law, tobacco companies actually said, well, we have to prove that smoking causes lung cancer in Lao people. And this was in the late 90s. So very difficult to understand how policymakers, even in this day and age, would actually buy into that kind of an argument. But South Korea, for example, an wealthy nation, there was a case, there have been cases filed against tobacco companies to recoup some of the losses for healthcare. And judges have thrown out those cases because they said there aren't any Korean studies linking smoking and lung cancer, as if Korean lung would be different from US lung or elsewhere. So tobacco companies use pretty much the same arguments, but like Mike said, the way they get a response is really different. And I think we need to be stepping up our game in terms of bringing the offense from the industry side to actually us suing the tobacco industry more, because they actually then become busier with trying to defend themselves rather than making problems for the rest of us. Australia, for example, their response to the litigation on plain packaging was to tell the industry, well, go ahead and sue us anyway, we'll defend our legislation. But we don't have that kind of similar response in low and middle income countries.
You want to go first? No, go ahead. I think I like to say is that if it has sometimes, for those of us looking at this for more than a decade now, sometimes we feel that there is like a bag of tricks, and the bag of tricks have different layers. So they go with the first layer, and it's the same bag of tricks no matter where in the world it is, and they go with the first, and if it sticks, that's great. If there's a big response, they go to the next layer. And if that stick, they stop there. And if the government response, and I think the government response, it's often more a matter of what kind of support than resources. I have seen many low and middle income countries put up very, very strong response. On the lawsuit, Jamaica was threatened, their law was threatened, and the industry filed a suit, and they said, go ahead, file. And they kept going with their legislation, and it was on the day for the industry to present their arguments to the court, they withdrew the suit. So it was a threat, and it didn't stick. So they're gonna try probably something else. Again, so it's sort of like, I don't think they are that different from country to country. I think what the response is different, but also highlights to me the fundamental need to improve the networking of support within countries and between countries, because the industry often comes. So when I did some work with Solomon Islands, and they came to the Solomon Islands and says, well, we did this in Australia, and it worked, so you cannot do this. And luckily at that time, there was a good network, and then Australia came back and said, no, they didn't. That's a lie. That's a flat-out lie. But again, this sort of networking, it needs a lot more structure. I think exists right now through the civil society, exists a little bit through WHO, through some academics, but there isn't really a concerted effort, almost like a clearinghouse of responses to industry that any country could use anywhere, because I think we could probably put one together, but there hasn't been really an effort, correct me if I'm wrong, to do this in a way that will be easy and accessible to anybody who wants it. So it happens a bit ad hoc right now. If we hear about it, if we know about it, and we call, it's like, is it true that your government has a memorandum of understanding? No, it doesn't. No, it doesn't. So it's like little telephone game goes around, and you get the answers. And by the way, Solomon Islands end up having a very, very strong tobacco control legislation passed about, I think, a couple of years ago, a year and a half, 2 years ago. But it was there was a lot of efforts from the industry to try to stop that from happening. So again, it was lucky at that time that there was a good network to support providing the type of answers that the Minister of Finance in the Philippines, because the arguments, like Mike said, are pretty much the same.
I'll keep my Brazilian citizenship in case I get kicked out of the United States, in case they take my American citizenship. With this comment, there is a reason that we do not see a lot of fight with the tobacco industry in this country. We're not putting the fight. No, not like the Philippines. Brazil lives in litigation with the industry. I mean, because so, and here we don't. But it's not because we're not fine. We cannot even approve the warnings in the cigarette packs in this country. So that makes us wonder why we're not fighting the tobacco industry in this country.
If I could just throw this out to the audience also about doing research, you all have your own networks and you all work at the community level. It'd be really great if we could get information from the communities about what the tobacco industry is doing. Just like Stella was saying, an example from the Pacific was Tonga tried to increase their taxes, and BAT, British American Tobacco, went to their finance ministry and said, well, if you raise your taxes, you'll have all of this illicit trade, a lot of smuggling coming in. And they cited the example of Hong Kong, which had increased their taxes over the years, and true enough, there was an increase in illicit trade. But when we actually wrote to our Hong Kong colleagues, they actually refuted what the British American Tobacco people were saying in terms of the tax increases, the decline in prevalence, and the increase in illicit trade. So the correlation that the industry was making was not exactly the same as what the government of Hong Kong was saying. So at the end of the day, Tonga said, well, you're giving us all of this BS, so we won't listen to you, and they ended up increasing their taxes anyway after getting the right information from Hong Kong. So it's important to share information, and we can't do that all the time from the outside. So the best source of information is really at the lowest level, at the community level, and getting that information out would be really, really helpful.
If you wanted to make one more comment.
I can't leave this session without saying a word about the period of transition that we're in, however. And I said from the podium I wouldn't speak about e-cigarettes, but last week I was in Washington and I spoke to 150 tobacco industry executives and vaping company employees and their law firms. And the tobacco industry is spending literally $1 billion to come up with alternative products that are not combusted. And that will introduce a dimension to this discussion that we haven't had to deal with yet, that will challenge directly Section 5.3 of the Framework Convention. And there's already a very heated debate in the public health community about these products. But the fact of the matter is that they are looking at developing products that purportedly present less harm, and will be seeking governmental approval for these products in a way that's never been done before. How that reflects and shapes what we do is unknown, and I don't want to open up the discussion here. I just said that I don't want someone saying, you mean IOM had a panel on tobacco control and never mentioned this issue? So I feel like I've met the obligation of mentioning it.
Thank you for that. All right, please help me in thanking our panel, and we have a 15-minute break.